Hello, everyone, and welcome to today's program, Taking Control of PKD. My name is Chelsea Tolner, and I am the Senior Director of Community Impact and Public Health for the NKF's Greater New York team. We are so excited to be hosting this program today, and for everyone who is tuning in both on Zoom and on Facebook, thank you for joining us. Before we get started, just a couple of quick housekeeping items. We'd like to ask that anyone who is joining from Zoom to please keep yourself muted until the questions portion at the end of the program. We also do encourage all of you to ask questions. So if you are joining from Zoom, you can put your questions in the chat box. And if you're joining from Facebook, you can ask your questions in the comments, and we will hold and answer everybody's questions at the Q&A portion at the end of the presentation. We're going to jump right into what we'll be covering today. We're going to learn a lot about many topics related to PKD, including pediatric and prenatal considerations, how we read and understand what our blood work means in PKD, how and who should be screened for PKD, how we screen for hypertension or high blood pressure in PKD, how teamwork is important, how to engage with our physicians, our medical team, and our family, and to develop important questions for our team. And lastly, what can be done with diet and lifestyle to help slow down PKD. I'm now going to turn it over to our facilitator of today's program, Dr. Priya Deshpande. Priya is a nephrologist and is the lead for the PKD Partner Clinic, designated through the PKD Cure Foundation at Mount Sinai. I'm going to turn it over to Priya, who will introduce you to the rest of our speakers today, and we'll get started. Thanks for being here, and thank you, Priya.
Thank you so much. Hi, my name is Priya Deshpande. I'm one of the faculty nephrologists at Mount Sinai Hospital, and it's my pleasure to be here. Thank you so much to the NKF for hosting this event. I'm honored to introduce the three guests that we have today. Our first guest, next slide, please. Sorry, if you can advance the slide. Our first guest is Nercy Sullivan. Nercy is an entrepreneur and an activist working to support the polycystic kidney disease community. She's a founding presence of Alchemy Space in New York City, where she's been helping clients to be their most beautiful selves for many years. She feels that beauty is related to wellness, and Nercy knows that really well. She has her attention focused on helping the patients of the PKD community to activate their most healthful selves. Nercy grew up in a family where there's a deep-rooted history of PKD, and like her mother, grandfather, and 5 other siblings, she has struggled to sustain wellness. This led her to explore other healing paths. She's a Kundalini yoga instructor, an Instagram influencer, and a kidney patient. She has deeply investigated in how to create health and a stronger self, even under conditions of chronic disease. And she's a sharer and a carer, determined that others might benefit from her hard-won knowledge and wisdom. Next slide, please. Meg Munits, she's also joining us today. Meg is a registered dietitian, nutritionist at the Kidney Nutrition Institute, and a community leader for the Polycystic Kidney Disease Foundation, and a mother of 3. Her passion for kidney health began in 2011 when her son presented with ADPKD in the womb. He inspired Meg to pursue a master's in nutrition as she yearned to know more about what to feed her son, along with the rest of the family. Since then, it has become her mission to help families navigate nutrition therapy for their growing children with kidney disease. Next slide, please. Dr. Jeffrey Saland is the chief of the Division of Pediatric Nephrology and Hypertension at the Mount Sinai Kravis Children's Hospital, and the medical director of the Pediatric Kidney Transplant Service at the Recanati Miller Transplant Institute of Mount Sinai. Dr. Saland's clinical practice involves the entire range of diagnoses and treatment of kidney disease in children, including genetic diseases and diseases due to cysts. Those are our wonderful speakers and guests for today. I'm going to give a quick introduction. I'm so excited to be here, especially because PKD Awareness Day happened on September 4th. So I think this is a really great program to have. So just briefly, autosomal dominant polycystic kidney disease is the most common hereditary kidney disease and affects about 10 million people worldwide. It affects males and females alike and can affect patients of all racial and ethnic backgrounds. ADPKD follows an autosomal form of inheritance, which pretty much means there's about a 50% chance of passing the PKD gene from during a pregnancy. The most common genes associated with PKD are the PKD1 and PKD2 genes. Mutations in the PKD1 gene accounts for about 80% of patients with PKD, and mutations in the PKD2 gene accounts for about 15%. 10%, however, of patients may not have a known genetic mutation or may have rarer mutations. The gene mutations ultimately cause abnormal cystic growth in the kidneys, and this whole process starts in utero and progresses over decades. The cysts actually form in a very small number of nephrons in the kidney, and they progressively enlarge, causing compression and obstruction of normal kidney structures. This process happens in both kidneys, and over time, the kidneys get larger and larger. Despite the damage that's happening, though, over so many decades, the kidneys can really retain normal kidney function for a very long period of time. But at some point, the kidney function goes down. And typically, the ADPKD associated with the PKD1 mutation is more aggressive compared to the PKD2 mutation. At this point, there isn't a cure, but we're here at this webinar to pretty much try to come to discuss several strategies that we can help empower patients and their families to better take control of this disease. As I mentioned, this condition starts really early in life, in utero. And I think it's really important to start from the beginning in order to understand how ADPKD manifests in kids and how to approach it. And for this segment, we'll welcome Dr. Jeffrey Saland. Thank you so much for being here, Dr. Saland.
Yeah, it's my pleasure to be here. I know sometimes people often don't realize that children can be affected at all with a kidney disease. And I think that people with PKD are naturally more understanding that this is something that in fact is a lifelong condition. And so having a knowledge of that and being able to find a doctor that can give you advice is important about that.
Absolutely. So in your clinical experience, how does PKD, what are the symptoms in pediatric PKD, and how do these kids typically manifest, or how is the condition even discovered?
Yeah, that's a great question. And it's, I'm both happy to say, and I think in some ways it's frustrating too, but I'm happy to say that most kids do not have a single symptom, not a single sign. There's nothing external at all that would indicate that the child has any type of PKD. And there may be no blood test, there may be no urine test, and in fact, there may be no indication from an ultrasound or kidney imaging that there's anything amiss at all. And so, again, I love that. I love the fact that children are not having symptoms in general and that they're well. At the same time, I think that there has to be an awareness that this is a condition that, because it can genetically manifest from an early age, it's present in the DNA, that this process, starting from an early age, can be managed. And to have that awareness is probably the most important thing, so we can talk about, as a lifelong goal, how do we help minimize the chances that this is going to become an important medical condition in the child's life.
Absolutely. So it sounds like this, it's more of a condition at this stage as opposed to disease, because these kids are having very normal kidney function for the most part. You had mentioned DNA, and I was wondering, ultimately, how do you approach screening in pediatric patients? I guess particularly those who have a family history of PKD. When do you opt for getting an ultrasound at some point? How do you approach?
So yeah, and I think the question obviously comes up the most in families where there is a family history. And the answer has changed, but still really does remain with the family and their preference. Medically, I think it's important to know if a child has PKD if they are having any signs. And the signs might be something silent, like high blood pressure. So anybody in a family with PKD, even during infancy, should have their blood pressure measured. Because if that were elevated, then it would be more likely to say, look, we have to figure this out to know if this is a person who is manifesting symptoms relatively early. If there are other symptoms at an earlier age, whether it's pain, blood in the urine, those types of things would really lead me to suggest, yes, we should really figure this out. Is this a true genetic diagnosis of PKD, or is this something that's not related? in those asymptomatic cases, which again is the majority, that becomes a true family preference. I do think there's been a shift, and I know you're going to talk about this later, because there are so many things that we can do that lower the chances of PKD becoming a bigger problem, so we can minimize the size of the issue. My personal preference is to suggest screening for all potentially affected kids, and then use that information to give them tools to be proactive, to manage their risk, not to be unaware of the risk.
Absolutely. Do you suggest screening with genetic testing, or do you suggest screening with ultrasound? How do you, what are the modalities available for screening patients?
So DNA testing has become pretty simple, and even in a baby, we can do it with, even without a blood test, you can do it with a swab of the cheek. In an older child, they have a lot of fun. They spit and they fill up a tube. It's actually quite an adventure for some younger kids. They actually love that test. But there's many ways to do it, and it's a simple test. It's non-painful, but again, it yields that information, and the genetic testing itself has become so good that there's very rarely what I would call an error or some uncertainty there. It's even more valuable when a family already knows which genetic mutation is present, and you can do what's called targeted testing. So that's the best way to do it. Ultrasounds are also potentially useful, and we do check it in patients that we know to be affected or to have symptoms. But again, you could have the gene, you could have the PKD condition, but have a completely normal ultrasound, potentially up to even age 40. And so it's not necessarily the best way to screen. It wouldn't be the only way to screen for sure. So genetic testing is really the best, most precise way.
Great, thank you so much. I was wondering also, how does the diagnosis of PKD, when it's diagnosed in utero, affect a child's overall prognosis? Is there any indicators that earlier diagnosis in children is associated with a poorer, with more difficult manageable disease?
Yeah, that's actually one of the things that expecting parents and those with young kids really get concerned about. Wow, if this is sort of a disease that typically shows up in adults, and I already see it in the fetal stage of development or a young infant, does this mean that my child is going to have a worse case? And I guess the best technical answer is that we're actually not sure. Prenatal ultrasound didn't exist a few decades ago, and then it's gotten progressively better. So our ability to see abnormalities has gotten way better. And so I think we don't actually know for sure what those adults with PKD now had when they were fetuses. So I think I wish I could say absolutely this is not an issue, but my clinical practice over the last couple of decades tells me that what I think is that it's not necessarily true that just because we can detect it by an ultrasound in a fetus, does this mean this is absolutely going to be a more severe case? I have many patients where that is the only manifestation. I have patients that had this manifest in fetal life, and by the time they were born, their kidneys look normal again. And I've had everything in between, children who had a cyst and it disappeared. I don't think it's necessarily true. I've not really seen a correlation between the early diagnosis when it's minimal to a long-term outcome. The exception to that is when we see very large kidneys affected by many cysts and something that would look severe even in an adult. And that's not really new. That's not kind of a modern scenario. That's something that we've known that a very small percentage of children will be affected by a very early and aggressive form of PKD. And that's not necessarily a part of screening. That's something where they already have a kidney disease, and we're not talking about just the fact that it was detected in an asymptomatic way.
Understood. Thank you so much. Are there any additional studies that you recommend for asymptomatic children with PKD besides measuring blood pressure and confirming their kidney function?
Yeah, so we do, of course, we get that baseline ultrasound at a minimum, and we check it at least a few times during childhood. I don't necessarily see a lot of value in watching it every year. You can sort of overwatch if there's not a lot of activity and there's a very few cysts, maybe doesn't necessarily need to be checked every year, but it varies from patient to patient. I do recommend a heart sonogram, which is called an echocardiogram. And the reason for that is that there's a small but important association between PKD and the presence of some congenital abnormalities of the heart valve. So they're usually pretty minor. They might be, instead of 3 leaflet valve, it might be 2. There may be some differences in the width of the large blood vessel that comes out of the heart called the aorta. And those can be relevant for a very small number of people, but it's one of those things that, because it's something you're born with, you can check for it early on in life or just once. And if it's not there, you don't really need to look again. And if there is an issue, it's usually very minor. It's a very small number of people where it's important, but I think it's something that's worth checking. I think the only other thing that's potentially worth talking about, and I know you may mention this later too, in some families, there are some families that have an associated problem with aneurysms, so blood vessels, particularly in the brain. And that can be very worrisome because if they're not known about, they can be dangerous. In children, it's almost impossible for those to be present and cause a problem. That said, if someone's having a lot of headaches or there's a very strong family history, we will occasionally need to look for those aneurysms in a young child or a teenager. If not, we usually pass it on to you as the adult nephrologist and say, hey, this is probably something that as an adult you might want to consider screening, but not during childhood because it's unlikely to be present at that age.
That's awesome. I mean, fortunately, it's very rare in the adult population as well, but usually we offer screening to everybody as well. Is there aside from that, do you do any is there any utility for sonogram of the liver or anything like that? Is that something that you routinely screen for liver?
So that's a great question. And I know you're going to probably spend some time about the differences between males and females in terms of the effect of estrogen. And so I do tend to get at least one ultrasound on the liver in both boys and girls, but especially if I'm meeting a family for the first time and it's a girl who's either approaching puberty or is post-pubertal, I think that's an important thing to check and to give a lot of counseling. So if I can sort of use that question as a launch pad to say, well, what if mostly what we're finding is nothing, why do I exist? Why do I want to meet families? And it's really to counsel about these future issues and what can be done to mitigate risk. So the issue with the liver is that estrogen can drive those cysts. And so I can counsel at a preventative stage, in a girl who's not even gone through puberty, I can inform her of the potential risks of estrogen containing medications. I can inform her about lifelong risk of overall exposure to estrogen. And that may not be relevant when I'm speaking about it, but families and girls do hear that, and they can use that information in a prospective way. And that sort of echoes what we talk about for all sorts of therapy relating to the kidney and the liver and all of the other issues.
It makes perfect sense. Also, I was wondering how it seems like there's a lot for families to have to handle, and also how do families strike a balance between anxiety about the diagnosis in their child, as well as the benefits of knowledge and knowing what's out there and knowing what to do.
Yeah, and that's always hard. In pediatrics, it's a question that comes up for lots of different conditions. And I think for those of us who are parents, we understand that PKD is only one aspect of our families' lives and our kids' lives. And we're kind of thinking about all sorts of things that, could go wrong. And I think being able to understand and put PKD in the right perspective is really the best approach. And we've talked about this. You're going to throw up if you hear me say it one more time, but I like to joke that there's never been a better time to be diagnosed with PKD because we know so much more about it than we used to. We can mimic the effect of the medications like you'll talk about by encouraging lifelong habits for hydration. We can talk about, again, avoidance of estrogen-containing compounds and caffeine, things that drive cyst development and that even teenagers might already be getting exposed to. We can really coach on those lifestyle issues that I know are going to be talked about later in a way that's proactive. And so that word proactive replaces what I hope is worry. And I remind parents, I'm not going to tell you not to worry, because parents, that's your job. You kind of have to worry, but I want you to worry the right amount. I want people to worry more about car accidents and, safe sex and drug abuse and all the, scary things that we worry about with our kids. And I want them to put PKD in the right perspective, to understand the risk, but to really not overestimate its effect on life.
Absolutely. And I think, that's where where like all the support in the communities actually help in as well, just to have that support from the NKF community and from foundations like PKD Cure, just to help with parents and patients kind of put PKD in the right perspective, as you're saying. I was wondering if there are any, if you can think of any other like thoughts or concerns that parents have when you interact with them at your visits. Was wondering if there's anything else that's striking that that you'd want to share with us today.
I'm trying to think of things that jump out. I think the key is, for me as a doctor, is, every family is different and they come in with different concerns, and sometimes the parents aren't on the same page about their level of anxiety. And I think, both parents and children have to be patient with their parents have to be patient with their children, and take it at their own pace. And where one parent or the child might not be listening as well as they could at one visit, maybe it's going to be the next visit. And I think, again, it's a journey for every patient, and it's different. So I think that's really one of the messages I give people is, don't beat yourself up. This is going to sound obvious, I hope, to everybody, but I make sure I tell parents, especially a lot of times mothers feel like it was something they did during pregnancy. And I'm constantly telling people, even sophisticated people who know genetics, that this is not anybody's fault, that this is not something that you did wrong, and that there's no personal or characteristic that you could have done differently. And I think that's really important, because we all have an emotional response to this. And I think it's more pronounced for parents, especially during pregnancy and for infants. There's a lot of, for lack of a better word, people feel guilt for no reason. And I try to coach them through that it's not a part of this.
Absolutely. Thank you so much, Dr. Saland. I'm going to move on this discussion to adult polycystic kidney disease. And, before we delve into ADPKD in adults, let's specifically discuss how your nephrologist looks at your blood work. Unfortunately, in the interest of time, we'll only have time to go over some basics, but I can, if Chelsea can put the slide up for the basic metabolic panel, with a comprehensive. So I was going to get Nercy's input as well about how to make this discussion flow. One of the biggest concerns that patients come to me is, how do you look at your numbers? What do the numbers mean? And I think ultimately knowing your numbers is so powerful. And many decisions are based on lab work. Based on lab work, we can establish a diagnosis, monitor disease progression, develop a course of action for any treatment, and monitor responsive therapy. So when it comes to chronic kidney disease, any form of kidney disease, we typically look at the blood work. So let's first highlight a few aspects about the comprehensive metabolic panel, which I have displayed over here, which is pretty similar to the basic metabolic panel. There are a couple of differences. The purpose of these labs is to pretty much check your kidney function, which is based on your blood urea nitrogen. I'm not sure if you see my pointer. So the blood urea nitrogen and the creatinine level. Sorry, the blood urea nitrogen and the creatinine level. We also can check your electrolytes, mainly your sodium, potassium, chloride, calcium, and we can also check the amount of acid, which is called the carbon dioxide total, right over here. So I was, just to go over in a bit more detail about what the comprehensive metabolic panel or the basic metabolic panel actually has to offer. We pretty much can, based on the creatinine level, we can plug this creatinine level into a formula called the CKD epi formula. And then with the CKD epi formula, it comes up with a GFR, the estimated GFR. The estimated GFR is an estimation of your total kidney function. And this is an old slide, so there's no longer a distinction between races. When it comes to the estimated glomerular filtration rate, we can stratify where your kidney function is and what stage of kidney disease there is. There's another formula, blood test called cystatin C, which is another measurement of the kidney function. We can pretty much plug the cystatin C number into a CKD epi cystatin C formula, and that can also give us an estimation of your kidney function. In addition to the creatinine level, as I mentioned, we also look at the blood urea nitrogen level. The blood urea nitrogen is based on urea. So urea is a byproduct of protein metabolism in the liver, and it's excreted by the kidneys. Sometimes in kidney disease, this BUN or blood urea nitrogen level might go up. But we have to be mindful of other things that can sometimes cause this level to go up, like sometimes dehydration, sometimes steroid use, some other health conditions can sometimes affect the BUN level. The other really big aspect that I mentioned about the basic metabolic panel is to know what the electrolytes are. And specifically in kidney patients, we look at the sodium level, the potassium level, and the bicarbonate or the CO2 total, the carbon dioxide total levels. When it comes to the potassium level, sometimes kidney patients may end up having some trouble with that because potassium is excreted by the kidneys, and when the kidney function isn't optimal, the potassium level might go up. And in dangerous, sometimes it can go up to dangerously high levels, like over 6, and that can be a problem. In this case, this patient's potassium level is 4.5, which is excellent. So we want to try to keep our potassium level between like 3.5 to 5. That's the normal range. And you can discuss with your provider, and we're going to also hear from our wonderful dietitian and Nercy about their experiences with diet and controlling potassium. The other levels that we look at is we want to make sure that the sodium and the carbon dioxide total also stay within range. And there are strategies that we can discuss with your nephrologist to help make sure that stays stable. The other, I'm just going to go on to the next slide really quick. So this is how we pretty much determine stage of CKD, a state of chronic kidney disease, based on the estimated GFR from the creatinine. So stage 1 is when there's very mild kidney damage and the kidney function, the overall GFR is 90 or higher. Stage 2 is between 60 and 89. Stage 3A, stage 3 is cut into two components, 3A and 3B. So 3A is when the kidney function is between 45 and 59%. Stage 3B is when the kidney function is between 30 to 44%. Stage 4 is between 50 to 29%, and stage 5 is less than 15. So I think based on the creatinine that we talked about and where your GFR is, this is how we can have you know your numbers, and you can know, okay, I'm in stage 3B chronic kidney disease, and then because the management might be different from stage to stage. So I think knowing your numbers really helps empower patients and like understand what what medications they can take, what their diet should be. Just knowing your numbers can help with that. In addition to the basic metabolic panel and the comprehensive metabolic panel, we also look at parameters such as your hemoglobin level through a test called a complete blood count. The hemoglobin level is important for understanding where the level of anemia is. In some chronic kidney disease patients, there is anemia, which we have to treat with either a medication called erythropoietin or with iron supplements. We also look at bone health in patients who have chronic kidney disease, which is really, really important. The kidneys, interestingly, play a very important role with maintaining the balance between calcium and phosphorus. When it comes to chronic kidney disease, there is overactivity of a gland in your neck, like right at the base of your neck. It's called a parathyroid gland. They're 4 tiny little glands embedded in your thyroid. And these glands become more active and overactive in advancing chronic kidney disease. As a result, there can be like a shifting in the calcium phosphorus balance. And ultimately that can lead to weaker bones. So we have to make sure that we keep that parathyroid level in check. And we can, so I definitely encourage that you discuss with your nephrologist or your provider about your hemoglobin levels, as well as levels such as parathyroid and phosphorus and vitamin D. Lastly, we look at the urinalysis, and we sometimes measure the quantity of protein in the urine in order to help us understand the nature of the chronic kidney disease. In patients who have polycystic kidney disease, sometimes there can be some blood in the urine, especially after some episodes. If there's a history of kidney stones, or if there is a cyst rupture, we can see some blood in the urine, and we can see that on the urinalysis. Also, there's in certain settings, there may be some protein in the urine, especially in advanced chronic kidney disease. Patients can develop some protein in the urine as a result of damage in the kidneys. We can use medications like ACE inhibitors or angiotensin receptor blockers to help reduce the protein in the urine, which is better for the kidney outcomes. Polycystic kidney disease, though, we don't really see very high levels of protein in the urine. There are certain conditions like diabetes and other conditions that can cause a lot of protein, like more than 3 grams of protein in the urine. We don't really see that with polycystic kidney disease. So I think if that is detected, then we should probably do a further workup on the kidney disease and make sure that we're not missing anything. So I think it's definitely helpful to know, whether or not there is protein in your urine and how much you had in your last study, just to make sure that we're not like missing anything when it comes to managing the kidney disease. I was wondering if Nercy wants to chime in as well. That would be really helpful, just to make sure that I'm answering some of the right questions that patients have.
Absolutely. Hello everyone. One of my biggest concerns when I found out that I have PKD was understanding my blood work. After watching so many of my family suffering with anxiety, acidity, those were my biggest concern and my biggest fears. And once I understood my blood work, so for me, I'm 60, and there are 6 people in my family that got a kidney transplant between 45 and 50. And I decided, watching their lifestyle, how can I do different? And one of the things that I did was I started understanding and educating myself, my blood work. So when I understood that if my potassium was a level, but my uric acid was high, then I had to shift my diet and I was able to manage it. So at this point, I have a condition, my GFR is 13, but I feel great. I work out 1.5 hours a day. I have a full-time job, but because I manage my condition with Kundalini yoga. I meditate, I exercise, I hydrate pretty well, and I follow a diet that supports my body pretty well, my kidneys can work okay. So I don't have symptoms right now. I'm not symptomatic, even though I'm in a waiting list for a kidney transplant. I am hoping to postpone it as long as possible because of the lifestyle that I am living.
That's incredible. I think that's kind of, yeah, exactly. Like knowing your numbers, knowing where to adjust your lifestyle, where to adjust your diet is definitely very useful, very helpful. And just for our audience, Nercy had mentioned something called uric acid, which I didn't mention in the lab work that I was going over just now. Uric acid is a byproduct of certain protein metabolism as well. The proteins are called, there's a compound called purines that is very common in red meats and certain seafood like scallops and shrimp and shellfish. Sometimes in patients with chronic kidney disease, there's that having a diet that has a high amount of purines can increase that uric acid, and that can lead to symptoms like gout. So I think it's great with Nercy's strategy for using diet to help manage all of this. That's really like fantastic. I mean, Nercy, I was going to ask you, how do you work with your medical team, and who is in your medical team to help you manage manage your disease at this point?
I work with a team of nephrologists and a nutritionist. And it's really important for me for the past year and a half, I've been working with a nutritionist where I am taking tolvaptan. So this is the medication to reduce the growth of the cysts in the kidneys. And since I started doing this program, I'm also taking another supplement to neutralize the acidity and keep my body alkaline. So once a month, we together read my blood work, and she makes recommendation into whatever it is that is off in my system. So if this, like let's say last month, my uric acid was a little high. So she recommended like what kind of diet I should implement. So now I need to eat more broccoli, more green, more fiber into my diet. And by the next blood work, automatically I shift my diet. So whatever numbers are off, we are able to work on them, and we can look at the trend, what happens in my system. And when I follow all her advice, I do really well. Once in a while, I might go out for dinner and I might have a bad week, and I know how I feel. I don't even have to wait to see my blood work to know something is off, because my diet shows me that something is off, and I can adjust it by shifting and going back to my diet and the supplements. So it's really incredible. They say you are what you eat. And through my past 4 years becoming a plant-based eater, I noticed it is incredible, the shift in the level of energy, the level of, I have no anxiety, I have no acidity, and I enjoy the meals that I prepare, and I feel proud of what I bring into my home. So I highly recommend everyone to really educate yourself. There are so many classes and nutritionists that target specifically kidney condition. When I became a plant-based eater, I was taking general classes, and it was wonderful, but I didn't realize that they were saying, eat a lot of spinach, eat almond. And then even if those 3 things that I started getting out of my diet, like beets, almonds, and spinach, I was eating it by the pounds because I didn't realize it. I thought as long as I eat plants, I'm good. It was not good enough. It has to be more targeted and specific and clear. And once you have that information, it makes a big difference.
Absolutely. And I'm going to try to get Meg's involvement in this conversation, since we're talking more about diet and lifestyle, which I think is super important. Meg, how do you work with patients to tailor their diet? How do you how do you pretty much integrate a specific diet plan for patients who have based on their needs?
Hi, thank you for inviting me here. That's a great question. And I think the first place to start is to really reflect on the eating patterns, because this is, one of the benefits I think of PKD is that it is a family disease for the most part, for most families. So, that's a great place to start, because everyone can eat the same. And, take a look at, like, a great place is just look at what your dietary pattern is for the week. How much are you eating out? How much, processed foods are you eating? Are you drinking enough water? Like, those are great places to start, because you need the water for hydration, for your kidneys to work efficiently. And the processed food and eating out is going to bring in a lot of sodium. And so those are great places to sort of, add in more water and eliminate things that are bringing in a lot of sodium. And then the next step would be, am I eating an efficient amount of fruits and vegetables? And, because those are going to be good also for fiber, bringing in fiber, which will help clean out your system. And, are those fruits and vegetables, can I afford to buy organic, to help eliminate the toxins, because the toxins also add stress on your kidneys. If I can't, if it's hard for me to afford all organic, maybe just like the Dirty Dozen, and slowly make changes, because nutrition is one of those things that, in order to be sustainable and efficient, you have to make small changes. Everyone knows that if you try to, like, jump on a diet and make like 1,000 changes in a week, it's not gonna work. And that's where it benefits PKD too, because PKD is also a long progressing disease. So you have the time to make small changes to really affect your family. And as Nercy was saying, she has gone sort of the plant-based route, which is great because it helps eliminate the purines that you mentioned. So cutting down on red meat. But again, it may not be great for everyone. So I really encourage people to, meet with a nutritionist and examine, what your lab work is, what your symptoms are, because that's where nutrition sort of takes a personalized targeted nutrition therapy, because we can work, like Nercy said, with your blood work. So if things are out of the normal limits, we can target those based on what you're eating, what you should be eating. And I really want to emphasize that, we want to nourish you. We don't want to restrict, things and, I can't eat any sodium. No, because your body needs sodium for many of the pathways, for lots of the metabolism, for your muscles, it needs it. So it's just about finding that balance where you're nourished, and then you're also, sustaining your kidney function and kidney health.
Absolutely. And I was wondering, like, at what point should a patient see a nutritionist? Should they be seen, like, as soon as they're diagnosed with hypertension, or should they be seen when there is manifestation of kidney disease? When is a good time for sending a patient to somebody wonderful like you?
I would say that there's different times. I have families that come to me and just want to know, like, am I doing everything I can? And sometimes they're doing, like, amazing, like they're like milling their own flour and making their own bread. And it's just like, that's just one extreme. But, sometimes they'll just do a check-in with me and say, is there anything that you can see that I can be doing better? And, maybe it's just a matter of, like, well, instead of, buying store-bought cookies, can you find the time to make cookies? Or, just little small changes like that can reduce the phosphate that a family is consuming, based on the preservatives. So, and then sometimes families will come to me and say, my child's kidney function is at a certain level, right? So it can change by the stage. So like the amount of protein that they're consuming. So, so we want to look at like what stage they're in, what their symptoms are. So you really can see a nutritionist at any point. It's just, is it for something that you just want to evaluate how you're doing, or if you really you think to make some major changes based on the condition of the person that has PKD.
That's awesome. Thank you so much. Just to put that out there, blood pressure control is definitely one of our top interventions for managing adult PKD. It's probably one of the most preventing blood pressure and treating blood pressure pretty much helps with reducing kidney growth and helps with protecting the heart from enlargement and from even coronary artery disease. So I think definitely working with your nutritionist plus like your provider, your doctor, to help with combating blood pressure is like paramount for our PKD patients.
Yes. And just to add on to that, activity level really affects blood pressure also. Absolutely. So even at a young age, if you can get your child in a sport that is conditioning, so like swimming or track or something that establishes the foundation for life for their condition.
Fantastic. Nercy, is there anything that's worked for you, particularly with blood pressure in terms of activity level and exercise?
Absolutely. About a year ago, my blood pressure was really high and they tried to manage it with medication and nothing was working. And I started doing Kundalini yoga and I noticed how my whole life started shifting. So I decided to go and do a teacher training program. I wasn't even thinking of teaching. I was just trying to do it for myself. And the more I did Kundalini yoga, it was a system that then every time I started doing Kundalini yoga, I was more aware, what am I doing for the rest of the day? Am I having enough water? So I created a system that combined with meditation, movement, and exercises and the diet. It really changed my diet to a degree that I feel great. I thought I was actually called last week for a kidney transplant, and I say I'm not ready yet. I'm feeling amazing. So I do believe that if I continue with this, I hope that I can push it as far as possible. And hopefully by the time I need it, there will be a new things available for me.
Absolutely. I think at this point we were going to open up our our discussion to any audience questions. If Chelsea can help with
Sure. Yeah. Thank you. And thank you all so much for your insight. I'm going to pull up some of the questions we've been receiving, and feel free to still send your questions in as we go through. Again, if you're on Zoom, you can send your questions in the chat. And if you're on Facebook, feel free to submit your questions right in the comments there. But one of the questions that we have received is, I believe this is something that Dr. Saland will answer. If my child is diagnosed with PKD in utero or early in life, does it mean it's going to be a more difficult or worse case than average?
Yeah, so I touched on this a little bit before, and I think the answer is, for the most part, I don't think it does. I don't think the most technically correct answer is that we probably don't have the number of decades of follow-up for the modern type of prenatal sonograms and prenatal screenings that we do these days. We just don't have 40 years of experience with that. So it can't really answer that yet. But my impression over the last, say, 10, 20 years is that for a case that's basically asymptomatic, it doesn't seem to be any different than for cases that were diagnosed for other reasons or for screening later in life. And the exception to that is the very uncommon case of a fetus or a young infant that really has a significant number of cysts, very large number of cysts. And that's something that a pediatric nephrologist, or in some cases also a prenatal obstetrician, can sort of help put that in perspective. Is this essentially asymptomatic? Is this a very mild looking thing? Is it just enough to kind of diagnose, or is it really representing a severe, already progressed form of PKD? I think that's the big distinction.
Thank you. And then I think too, we're getting a couple of questions here about, nutrition and a healthier lifestyle. So I think just to kind of pull back a little bit, obviously we have so many great people here on this program that can speak to this. So I'm sure, it can feel really overwhelming to receive this diagnosis, or to have, to be learning more about this and learning about yourself and your body when you're dealing with PKD. So I think this will be something that Meg and Nercy can probably team up together to respond. But can we just speak a little bit more to, how can someone approach having a healthier lifestyle? Like, what are some of those basics to kind of get them started?
So as I mentioned, just take a look at your lifestyle, like take a step back and just look and say, are there any improvements throughout the day that I could change? Just take it really slow. Like, don't beat yourself up. Be very supportive and loving of yourself, and say, what is there an opportunity, instead of buying lunch, can I make it lunch? Can I do stuff like that? I would also recommend looking into clinical trials. There are sometimes some clinical trials that are investigating diet or intermittent fasting. There's also a great nutrition program that Nercy actually did called Renew, that takes you through a 3-month program on doing plant-based, ketogenic, oxalate management. And it's just a great opportunity to sort of explore different therapies in a healthy, supportive environment.
Absolutely. I also, as Meg mentioned, I did a Renew program. Something I highly recommend everyone, once doing it alone is really hard. But I really started feeling more comfortable once I did those programs, because they touch on into understanding your blood work, understanding where you are, and from there, then you can do more. So once you learn where you are, you can manage, what do I need? How can I eat? How much water do I need to drink? And having that support is really amazing. And I highly recommend everyone educate yourself and get yourself a nutritionist to bounce off questions and ideas. So when you speak with your doctor, you understand where you are better.
Great. Thank you all so much. And we do have one more question. So we had someone write in, I'm 72 and have been dealing with kidney cancer since 2007. 5 surgeries later and in remission for 5 years, I was recently diagnosed by a nephrologist with stage 3B kidney disease. He indicated that I will most likely need dialysis in 12 to 18 months. Any advice? I know this is a little bit outside of the specific PKD realm, so I'm not sure if Priya or Dr. Saland or anyone else, feel free if you can speak to this a little bit.
Sure. I can try to help a little bit. I think the progression from stage 3B to end stage kidney disease, in typical, ultimately that's a pretty big jump to make. Honestly, when you're in stage 3B, based on that KDIGO GFR chart that I showed, that means that your kidney function is between 30 and 45%. To go down to 15% in about a year, that's a huge jump and a huge decline in your GFR in a year. So I think it's probably worth looking into other reasons why there may be this accelerated kidney disease. Sometimes is there another compounding process on top of that? Sometimes there are other blood work that can be done to make sure that there's no inflammatory conditions or anything like that might be contributing to this it's what it sounds like, kind of a rapid progression. So I definitely recommend that you speak with your nephrologist and say, this is there anything else that we can do to help slow this down? Kidney surgeries. When it comes to kidney surgeries, sometimes there is a reduction of the kidney mass. And when there is reduction of kidney mass, that does lead to progressive kidney disease. So is it purely because perhaps you have smaller kidneys as a result of surgeries, and that's why there's this risk of rapid progression? But honestly, going from a GFR of 30 down to a GFR of 15 in a year, it just sounds like a very accelerated form. So I would recommend that investigations be done to make sure that there's nothing else that we're overlooking.
And I think that no one would doubt this. I think 72 makes you definitely one of the older pediatric patients I would talk about, but I think we're all young at heart. But as a general idea, and I'm one of those people who's kind of direct, and I think it's always really important to be direct with your doctors, obviously in a really respectful way. But I would ask the question, how about a kidney transplant? Never wrong to ask that question. There may be some reasons why that doesn't seem to be something they've proposed. Maybe they have, but I think anybody who in the short or long term is looking at dialysis as an option should also be considering transplant as an option. It's, when possible, almost always the better option. It's not always possible, and I think that's something to know about, but don't be shy about asking about that.
Thank you so much. And actually, I'm going to, just for those who did ask questions, I'm going to drop my email right now in the chat on Zoom. And if you have any further questions or you want to further discuss or need any resources, feel free to reach out to me directly and we'll get you the answers and resources that you're looking for. All right, so we're going to wrap it up. Thank you so much for everyone for joining us today. Thank you so much to our panelists for making today possible. There is a survey link that will be dropping momentarily in the chat box of the Zoom and in the comment section of the Facebook. We'd love your feedback on the program if you'd be willing to click that and give us some feedback. We appreciate everyone's support and commitment to the National Kidney Foundation and its programs. Be sure to keep an eye on our website for upcoming programs and feel free to reach out to us if you need anything at all, and we will make sure that you are followed up with appropriately. Thank you, everybody.
Thank you. Thank you.